Welcome to the GMJ podcast, the official podcast of the Georgian Medical Journal.
In this series, we present structured discussions of peer-reviewed contributions published in GMJ, examining their implications for clinical practice, medical education, and health policy.
This episode reviews the article titled, "The Launch of the European Union of Medical Specialists Public Health Section Living Platform."
To start things off, if a new health crisis crossed European borders tomorrow, you'd probably picture a massive high-tech control room springing into action.
Right, giant screens, alarms, centralized data.
Exactly. A unified response instantly beamed out to hospitals everywhere. But the reality, that room doesn't exist.
Instead, you have dozens of different countries speaking different languages, relying on totally different medical standards.
And operating completely distinct health policies. So, how do you prevent a continent-wide collapse when a challenge ignores borders?
It is the ultimate logistical nightmare.
Yeah.
You are dealing with sovereign nations that fiercely protect their independent health systems.
But they're highly vulnerable to the exact same transnational threats.
Right, and that tension is exactly what we're unpacking in today's deep dive. We are looking at the hidden infrastructure of European healthcare.
Our source material today is a brand new publication from April 2026.
Housed in the Georgian Medical Journal, or GMJ. But here's the twist. This isn't a traditional research paper with a standard hypothesis and conclusion.
No, it's the launch of an entire living platform built for the public health section of the UEMS.
Our mission today is to figure out how this digital blueprint is trying to build a unified healthcare nervous system for Europe.
Which is a massive paradigm shift. You are looking at an academic journal pivoting to host a live, interactive policy environment.
Yeah, to really grasp the magnitude of what this platform is trying to achieve, we have to start by looking at the sheer scale of the architects behind it.
Okay, let's unpack this. The UEMS stands for the European Union of Medical Specialists.
They were established back in 1958, and today they represent over 1.6 million medical specialists across Europe.
1.6 million. That massive workforce is broken down into over 40 different specialist sections and boards.
It is a staggering number of highly educated, deeply entrenched professionals.
And for decades, the primary mandate of the UEMS has been harmonization.
They are tasked with harmonizing postgraduate medical training, continuous professional development, and establishing baseline safety and quality standards across incredibly diverse European health systems.
I want to pause on that word, harmonization, because coordinating 1.6 million doctors sounds impossible unless you force everyone to operate identically.
Right. But from reading the sources, harmonization is not the same thing as standardization.
No, not at all.
If we think about standardization, it would be like telling every country in Europe they have to rip out the electrical wiring in every wall to use the exact same plug shape overnight.
Which would never happen. The financial and political costs would be astronomical.
Right, but harmonization is different. Harmonization is agreeing on the underlying voltage and building a universal adapter.
So that the power flows safely regardless of what the plug looks like.
Exactly. They aren't trying to erase national medical traditions. They are building the adapters so a baseline of safety translates across borders.
That is a brilliant way to conceptualize it. If a surgeon completes their residency in Italy, but decides to relocate their practice to Germany or Georgia,
standardization would demand they completely retrain under the German or Georgian curriculum.
But harmonization means we have already evaluated the Italian training protocols. We've mapped them against a shared European framework and verified that the baseline competencies match.
The adapter is the mutual recognition of quality.
So if you have 1.6 million doctors who need to harmonize, how do you actually execute that?
Well, the traditional approach for a massive international body is to hold a massive conference once a year, present a bunch of slideshows, and publish a 500-page PDF that absolutely no one reads.
Yeah, how are they avoiding that trap?
That is the exact trap the UEMS public health section realized they were facing. The specific group behind this new platform treats public health as the foundational pillar of everything we just discussed.
Right. They focus on workforce development, prevention, and policy coordination.
But they recognize that a static PDF cannot respond to real-time crises.
Which brings us to the actual catalyst for this new platform. In the GMJ publication, there's a welcoming statement from the chair of the section, Professor Kristiina Pacha from Finland.
And the secretary and treasurer, Professor Georgian from Georgia.
They don't just announce a website. They lay out an urgent case for why a living, breathing digital infrastructure had to be built right now.
They identify 4 core drivers of change that are essentially forcing the hand of European health systems.
Demographic shifts, increasing population mobility, emerging health threats, and growing system complexity.
Let's dig into the mechanics of that. Take demographic shifts. We often hear about the aging population as an abstract concept.
But how does an aging demographic specifically break a non-harmonized health system?
Think about the resource allocation. If a country like Germany has a rapidly aging population, their demand for geriatric care, chronic disease management, and specialized nursing skyrockets.
Right, and if their internal medical workforce isn't large enough to handle that spike, they need to recruit from outside their borders.
But if neighboring countries have entirely different protocols for chronic care management or different scopes of practice for nurses, that imported workforce cannot integrate smoothly.
The system bottlenecks. Patient care suffers because the adapters we talked about earlier haven't been built.
And then layer on the sheer technological and bureaucratic weight of modern medicine.
What they call system complexity.
Precisely. To solve these compounding crises, Professors Pacha and Kakadze realized they needed a constant, active mechanism for collaboration.
Not an annual conference, but a daily operational hub.
But I have to admit, when I first read about them launching a digital platform to solve this, my initial reaction was skepticism.
Oh, completely. We have all seen these corporate innovation hubs.
Usually, they are digital ghost towns. A glorified intranet with a welcome video from the CEO and a repository of dead links.
So what makes this any different?
What's fascinating here is the specific engineering they utilized to prevent that digital ghost town scenario. They built what they call a dual architecture platform.
Okay, dual architecture. The source mentions it's split into two synchronized layers.
The first layer is made up of dedicated national spaces. Each participating country gets their own digital real estate to present their national representatives, their institutional frameworks, and their specific policy innovations,
It allows the country to establish their unique context.
which respects their individual sovereignty. It acknowledges that public health in rural Finland looks very different than public health in metropolitan Berlin.
But wait, doesn't giving everyone their own national space just reinforce the exact silos we're trying to break?
That's a great question. If everyone retreats to their customized national dashboard, how does that actually force harmonization?
That is where the second layer of the architecture comes in. The platform integrates a shared European-level content layer.
This isn't just a bulletin board. It is an active translation mechanism.
Let's say Finland develops a highly successful, innovative policy for retaining rural healthcare workers. They post the data and the framework in their national space.
The platform's shared layer extracts that innovation, strips away the Finland-specific bureaucratic jargon, and presents the core evidence-based mechanism to the rest of Europe.
Via news streams, technical tools, and collaborative working groups.
So it acts as an API for health policy. It pulls the successful data from the local level and pushes it to the continent-wide dashboard.
Exactly. It bridges research, policy, and implementation dynamically.
If Romania is facing the same rural workforce shortage as Finland, the Romanian health minister doesn't have to reinvent the wheel or commission a 5-year study.
They can pull the harmonized framework directly from the platform. It takes local innovations and elevates them to a cross-country learning exchange.
To see if this actually works in practice, our sources included the real-world applications active on the platform on launch day.
The announcements from April 1st, 2026.
The platform is structured into 3 main components: countries, news, and resources. When you look at the news section, there are 2 specific updates highlighted from the World Health Organization.
Yes, and the selection of those 2 specific news items is incredibly revealing about the platform's true purpose.
The first one highlights WHO findings on global progress toward inclusive health policies for refugees and migrants.
And the second piece of news is the WHO officially welcoming the IOM, the International Organization for Migration, into the Global Digital Health Certification Network.
If you connect the dots, these news items perfectly map onto the threats that Professors Pacha and Kakadze warned about.
Population mobility and cross-border collaboration.
This isn't theoretical policy. This is the live ammunition of modern public health.
Let's bring the listener into this for a second. Think about the last time you had to switch doctors in your own hometown.
Just moving your medical history across the street can be an absolute nightmare of phone calls, fax machines, and incompatible patient portals.
Now, scale that friction up to an international level.
That is the ultimate stress test for European public health. Imagine a software engineer relocating from Milan to Munich for a new job.
Or, more critically, imagine a refugee fleeing a crisis zone, moving through Greece, arriving in Italy, and eventually being resettled in Sweden.
How does their medical history follow them?
It usually doesn't. Paper records get lost, or they're written in a language the receiving doctor cannot read.
And even if the records are digital, the technical friction is immense. Greece might use one database architecture.
Italy might use a legacy IT system from the early 2000s.
And Sweden has incredibly strict GDPR privacy laws that block the automated sharing of patient data.
Plus, they might use entirely different coding standards for the exact same disease.
That sounds like an unsolvable puzzle. How does integrating the International Organization for Migration into a global digital health certification network actually fix that?
A digital health certification network relies on a standardized cryptographic token, a secure digital asset that the patient controls, much like a digital boarding pass on your phone.
Oh, that makes sense. It contains verified health data, like vaccination status or chronic care prescriptions,
Translated into a universal medical code, such as the ICD-11.
By bringing the IOM into this network, the WHO is essentially saying, we are going to build the digital infrastructure so that when a highly vulnerable migrant crosses a border, their baseline health data can be securely scanned.
And instantly understood by the receiving country's health system.
But a network like that only works if the public health officials in Greece, Italy, and Sweden are all looking at the same technical blueprints.
And agreeing to accept those digital tokens.
Precisely. You cannot implement a digital certification network if the countries aren't talking to each other.
Which is exactly why the UEMS public health section built this living platform.
It provides the daily operational space for the public health officials of those diverse nations to align their legacy systems, navigate the GDPR compliance together, and agree on the technical standards.
The exact standards required to make that digital token work.
That makes the stakes of this platform incredibly tangible. They are literally building the communication lines required to keep people alive as they move across borders.
But that brings us to the final piece of the puzzle, and honestly the part that I found most surprising in the source material.
It's how this platform is being hosted and maintained.
Because any platform dealing with the health policies of dozens of sovereign nations can very easily fall into political gridlock.
This is where the structural choices made by the UEMS become just as important as the technological ones.
The platform is hosted by the Georgian medical journal, GMJ, and it's supported by the Public Health Institute of Georgia, or PHIG.
The source specifically notes that GMJ provides the academic infrastructure, meaning editorial independence, open access dissemination, and international visibility.
And then there's this very prominent disclaimer. The platform operates independently and does not represent an official position of the European Union institutions or affiliated bodies.
That disclaimer is the linchpin of the entire project.
But why? If this is about coordinating European public health, why not just have the official EU bureaucracy run it?
Why host a live, interactive, continent-wide policy platform inside an academic medical journal?
Because the moment you embed a platform like this inside an official governmental or political institution, it becomes subject to political constraints and the optics of failure.
What do you mean by the optics of failure?
Imagine a minister of health for a major European nation rolls out a massive, expensive new initiative to combat childhood obesity.
Okay.
After 2 years, the data shows the initiative is a catastrophic failure. It wasted millions of euros and didn't move the needle at all.
Wow.
If that minister logs on to an official EU-run government portal to report that failure, it is political suicide.
The opposition party in their home country will use that official government post to destroy them in the next election.
So the natural instinct is to hide the failure.
Exactly. On a political platform, countries only share their polished successes.
But in public health, analyzing failures is just as important, if not more important, than celebrating successes.
You need to know what doesn't work so other countries don't make the same expensive mistakes.
Ah, I see where this is going. This is the strategic value of academic neutrality.
By having an academic journal like GMJ host the platform, they have engineered an independent safe space.
In the context of a peer-reviewed medical journal, a failed policy isn't a political scandal, it's just a data point.
It's published as a retrospective analysis of suboptimal outcomes.
The academic framing strips the politics away and leaves only the evidence.
That is an absolutely brilliant structural hack. GMJ and the Public Health Institute of Georgia are essentially providing a politically neutral sandbox.
They are using the rigor and the protected status of traditional academic publishing to shield a highly dynamic, living policy network from the red tape of Brussels.
It guarantees that as the platform grows, the dialogue remains driven by evidence-informed decision-making and international academic standards, rather than institutional posturing.
The focus remains strictly on the science of public health.
So let's bring this all together. We started today by dismantling the illusion of a centralized high-tech control room.
Instead, we found the UEMS, an organization trying to harmonize the practices of over 1.6 million medical specialists across a fragmented continent.
We explored how the crushing pressures of an aging demographic and unprecedented cross-border mobility are forcing these nations to find new ways to collaborate.
And we unpacked the mechanics of their solution, a living platform with a dual architecture that bridges national sovereignty with shared European data.
Right. And by anchoring that entire system in the independent academic infrastructure of the Georgian Medical Journal, they've managed to create a space that allows for transparent, evidence-based exchange.
Without the fear of political fallout, Europe isn't waiting for a magical control room. They are actively building the digital adapters required to make their healthcare systems talk to each other.
It is a profound model of how to turn complex multinational friction into shared, actionable knowledge.
Which leaves us with a final thought to chew on. We spent this time looking at how this academically hosted dual architecture model is working to harmonize public health across the diverse nations of Europe.
But if this mechanism actually succeeds, if it proves that you can securely share digital health tokens across borders and transparently analyze policy failures in a neutral sandbox,
Could this be the blueprint for a true global public health network?
that is the ultimate question. The friction we see in Europe exists on every continent.
What would a platform look like if it connected every single country on Earth with this same level of transparent, evidence-based exchange?
Imagine a world where a successful disease prevention policy in South America is seamlessly translated and adapted for a rural community in Southeast Asia within weeks, not decades.
Until that global network is built, Europe is laying the cables for their own nervous system, and we will be watching closely to see how it fires.
Thank you for listening to the GMJ podcast.
For a full and detailed discussion of the topic presented in this episode, we invite you to consult the original article published in the Georgian Medical Journal.
A direct link is provided in the episode description.
We look forward to continuing these scholarly discussions in future episodes.